Fluid control and soft tissue management. Control of fluids and appropriate displacement of the gingiva are essential during tooth preparation to obtain accurate impression and for cementation. They enhance the operator visibility, increase patient comfort, and aid in extracting optimum benefits from the impression and cementation procedures. The various procedures used in control of fluids and gingival displacement are discussed in this video. Fluid control objectives: to remove fluids, isolate and retract oral tissues, to enhance operator visibility and patient comfort during tooth preparation, to prevent injury to the patient's oral tissues, to prevent aspiration of fluids along with restorative debris, isolate specific areas of the oral cavity and ensure a dry operating field in preparation for impression and cementation procedures. The methods employed may perform the task of fluid control, isolation and retraction of oral tissues. The methods are rubber dam, cotton rolls, saliva ejector, low vacuum suction, high vacuum suction, Sweetopter, anti-silagogues, local anesthetics. Rubber dam, used to isolate the tooth during restorative procedures. Used during preparation, impression and cementation of indirect restorations. Should not be used with polyvinyl siloxane. When used with the elastomeric impression materials, it should be lubricated and clamp removed. Cotton rolls. Simplest method of fluid control and isolation used during impression and cementation procedures. For isolating maxillary arch, a single cotton roll in the buccal vestibule adjacent to the first molar maxillary where the parotid duct opens is sufficient. For isolating the mandibular arch, multiple cotton rolls are placed on the buccal and lingual side of the prepared tooth. An alternative to multiple cotton roll is a single long roll placed in the maxillary and mandibular mucobuccal fold. Saliva ejector or low vacuum suction used for fluid control during impression and cementation procedures. Can be used without any assistance. High vacuum suction used for fluid and saliva removal during tooth preparation. It is a powerful suction equipment used with an assistant. It may also be used to retract the lips simultaneously. Sweetopter. It is a flange type of saliva ejector made of metal used for fluid control and tongue retraction during tooth preparation on mandibular arch and isolation during impression and cementation. Can be used with the patients in an upright position without assistance. Disadvantages: access to lingual surface of the mandibular teeth may be limited, may injure the floor of the mouth. It is not used carefully as it is made of metal. Cotton rolls placed between the blade and mylohyoid ridge may reduce this problem, contraindicated in the presence of mandibular tori. Anti-silagogues, drugs used to provide fluid control by reducing gingival salivary flow. This is especially beneficial during impression making. Anticholinergic drugs, atropine, dicyclomine, and propanthenol may be used. They are given 1 hour prior to commencement of dental procedures. They are contraindicated in patients having hypersensitivity to the drug, glaucoma, asthma, obstructive conditions of the gastrointestinal tract, and congestive cardiac failure. Clonidine, an antihypertensive drug, may also be used. It is safer than anticholinergics but should not be used with caution with other antihypertensives. It can cause drowsiness, which may not be desirable. Local anesthetic. In addition to pain control, the local anesthetics also reduce salivary flow during impression making. They act by blocking nerve impulses from the periodontal ligament that regulate salivary flow. Gingival displacement. The deflection of the marginal gingiva away from the tooth, also called gingival retraction or tissue dilation. Indications to provide adequate reproduction of finish lines, to accurately duplicate subgingival margins, to provide the best possible condition for the impression material, fluid control, to fabricate accurate restoration, thereby preventing periodontal disease, to expose the prepared finish line, to control the gingival crevicular fluid, to evaluate the depth and uniformity of finish line, allow refinement of finish line without laceration of soft tissues, provide access for the impression material to record accurately the finished margins and a part of the unprepared tooth beyond the finish lines, helps to obtain accurate marginal fit, which will reduce the marginal leakage and subsequent deterioration of the tooth. Methods for gingival displacement: mechanical, mechanical-chemical, chemical, and surgical. Mechanical. This method physically displaces the gingiva. Copper band, rubber dam, and magic foam. Copper band. It carries the impression material and displaces the gingiva. Impression compound and elastomeric materials have been used. One end of a copper band is trimmed to follow the contours of the gingival margin. The top part is plugged with resin or compound. A vent is placed to allow escape of excess material. Dental floss is threaded through the vent to ease band removal. The tube is filled with impression material and is seated parallel to the long axis of the tooth such that the contoured metal margins coincide with the free gingival margin, gently displacing them. No longer used routinely. It can cause injury to the gingiva and retraction is also minimal. Rubber dam. It is used when limited number of teeth in one quadrant are being restored and when preparations do not have to extend subgingivally. Clamps should be blocked out and addition silicone should be avoided as rubber interferes with the setting. Magic foam. It consists of compricap, a hollow cotton, and magic foam cord, a polyvinyl siloxane material. Prior to impression making, a desired size of the compricap is selected. Magic foam is injected along the preparation and inside the compricap and is placed over the prepared tooth. The patient is instructed to gently bite to hold the compricap. After about 3 to 4 minutes, the compricap is removed along with the magic foam cord. The advantages: easy to use with less trauma. Disadvantages: less retraction than cord. Hemostasis must be established prior to retraction. Mechanical chemical. A displacement or retraction cord is used for mechanically separating the tissue from the prepared margin and is impregnated with a chemical for astringent action and or hemostasis as impressions are made. Cord displaces the gingiva tissues both laterally and vertically. Ideal requirements of cords: dark in color and never red. Be made of absorbent material, strong enough to resist placement and should not snap. It should be available in different diameters to accommodate the varying morphologies of the gingival sulcus. Chemicals used. Cord is supplied impregnated with the chemical cord or may be dipped in specific chemical agents before packing into the gingiva. These cause a transient ischemia, thereby shrinking the tissues, help control gingival fluids and provide hemostasis. The most commonly used chemicals are ferric sulfate, aluminum chloride, racemic epinephrine 8% is also used, though not commonly used as it causes tachycardia. Classification: plain or impregnated, lubricated or non-lubricated, twisted, braided or knitted according to thickness. These are the different thicknesses available. Knitted cords are made of compressible interlocking chains which transport greater amount of chemical agent. Braided cords do not separate easily and do not unravel while they are being inserted. Knitted and braided are most preferred. The instrument used for packing the cord is called Fisher cord packer. It should be thin enough to be placed in the gingival sulcus without damaging the tissues, and the angle of the instrument should allow packing of the cord all around the tooth. The tip may be serrated to enhance grip of the instrument on cord. Displacement techniques. Two methods may be employed: single cord technique and double cord technique. Single cord technique, one cord is placed in the sulcus and the impression is made immediately following retraction after removing the cord. Double cord technique, two cords are used. One thin cord is first packed deep into the sulcus and left there during impression making to provide hemostasis. The second cord is placed over the first cord to provide retraction and is removed immediately prior to impression making. Single cord technique. This is the most commonly used method indicated for impression of 1 to 3 prepared teeth with healthy gingival tissue. It is relatively simple and efficient. The operating field must be dry, isolated with cotton roll, and fluid removed with saliva ejector. Cut appropriate length to circle the tooth 2 inches appropriately. If impregnated, moisten cord intraorally or dip in an appropriate chemical agent placed in the tapping dish. Single cord technique. Form a U shape and loop it around the prepared tooth so that the cut end on the lingual side. From the lingual side, grasp the cut end of the cord between the thumb and forefinger and apply tension very slightly in an apical direction. This apical tension would result in the cord getting tucked in both the proximal and labial surfaces. Use the cord packing instrument to secure the cord in the proximal area first. The instrument should be angled towards the tooth. Proceed to the lingual surface and facial surface beginning with the mesiolingual line angle. Cut off the excess length of the cord protruding from the lingual surface, leaving a small tag. This tag can be grasped for easy removal. Single cord technique. After 10 minutes, moisten the cord with saline and sterile water and remove the cord slowly to avoid bleeding. If active bleeding persists, ferric sulfate chemical can also be applied to the gingiva. Double cord technique. The double cord technique is indicated when making impression of multiple prepared tooth and when tissue health is slightly compromised with more than normal bleeding anticipated. A small diameter cord is placed into the sulcus. The end of this cord should be cut so that they exactly abut against one another in the sulcus. This cord is left in the sulcus during impression making. A second cord is soaked in the hemostatic agent of choice and is placed in the sulcus above the small diameter cord. The diameter of the cord should be maximum diameter that can be placed easily in the sulcus. 8 to 10 minutes after displacement of the second cord, it is moistened, removed, and the impressions are made with the first cord in place. After making the impression, the small diameter cord is moistened and removed from the sulcus. The chemical used. This is a recent development where retraction is achieved using only chemicals. Aluminum chloride containing Expasil. This consists of aluminum chloride containing paste, Expasil, which is injected into the sulcus prior to the impression making The paste is left in the sulcus for 3 to 4 minutes to achieve the desired retraction. It is washed off and impression is made. Advantages: achieve good hemostasis with less trauma. Disadvantage: retraction is much less compared to cord. Surgical: rotary curettage or gingitage, electrosurgery, and soft tissue lasers. Rotary curettage. It is also called gingitage. The concept of using rotary curettage was described by Amsterdam in 1954. Rotary curettage is a troughing technique. Epithelial tissue in the sulcus is removed by a rotary instrument while finish line is being created. This technique is well suited for use with the reversible hydrocolloid impression material. Rotary curettage must be done on only healthy gingiva to avoid tissue shrinkage. This technique can be used only when there is absence of bleeding upon probing, sulcus depth less than 3 mm, presence of adequate keratinized gingiva. Rotary curettage disadvantages: there is poor tactile sensitization while using diamonds, which can lead to deepening of the sulcus. It has potential for the destruction of periodontium with inexperienced hands. Produces controlled tissue destruction. High density current from a small cutting electrode produces rapid rise of temperature at the point of contact with tissues. The cells in contact with the electrode are destroyed by this temperature rise. An unmodulated alternating current is recommended for displacement. This is electrosurgery. Indications of electrosurgery are gingival sulcus enlargement and hemostasis, gingivectomy, and crown lengthening. Disadvantages: patients with electronic medical device, cardiac pacemaker, insulin pump. Patients with delayed healing because of debilitating disease or radiotherapy. Not used if attached gingiva is thin. Not to be used with metallic instruments as contact with them can produce electric shock. Better to use plastic mouth mirrors and saliva ejectors. It should not be used in the presence of flammable agents like local anesthetics such as ethyl chloride or other aerosols, nitrous oxide, analgesia, as electrosurgery can produce sparks during use. Soft tissue lasers. These are also used for gingival retraction similar to electrosurgery. Gingival displacement is an important procedure for fabricating indirect restoration, especially when subgingival finish lines are used. Gingival displacement is relatively simple and effective when dealing with high, healthy gingival tissues and where margins are properly placed. The most common technique used for gingival displacement is the use of gingival retraction cord with a hemostatic medicament. Retraction cords of appropriate diameter should be used. Thank you for watching.